Hi guys, welcome back. So this is now the fourth video in our series on antibiotics. So to recap briefly what we've done so far is we've looked at peptidoglycan synthesis, and then we looked at a few of the antimicrobials that we use that target that synthesis pathway by interfering with the construction, the synthesis of peptidoglycan. If you inhibit that synthesis, then you can't make a cell wall and the bacteria is going to lyse. We're now taking a little bit of a turn away from agents that work on the peptidoglycan on the cell wall. We're going to look now at aminoglycosides. As I said, these have a very similar name to the glycopeptides, so it's important not to get these confused. A good way to remember it is amino, and the reason that gives it away is that these act on protein synthesis, right? So the amino and the aminoglycosides tells you that it's going to be targeting protein synthesis. That's just how I remember it. Whatever works for you, just as long as you don't confuse yourself, really. The way that our aminoglycosides work is well, first of all, this is a few examples of them. You can see we're now getting greater and greater complexity as opposed to the beta-lactams. So these were developed later on. They originally derived from streptomycin. So streptomycin was a naturally occurring form. It was derived from a gram-positive rod, so gram-positive bacilli, which produces these toxins in order to kill off its competition. Gentamicin is also a naturally occurring one. This is quite often used now as well, although again, resistance is building. And that has a broad spectrum against all most gram-negatives actually are affected by gentamicin. So, again, as with all these classes, there's lots and lots and lots of different ones, and they're getting increasingly complex with different side groups and things added. So gentamicin, I guess, can be considered one of the natural kind of bases on which we've then added a whole bunch of different active groups to get different effects. Okay, so how do they work? They work, as I said, by inhibiting protein synthesis. So if we say here that this is a bacterial ribosome, the bacterial ribosomes are different. They're 70S compared to ours. They have a 50S subunit and a 30S subunit. And while this isn't a lecture on protein synthesis or anything like that, or the central dogma, we know that mRNA comes in, binds to the 30S subunit, and then it kind of chugs along while tRNA comes in, binds through anticodon-codon joining, and then you get this amino acid here that gets added to a chain, and so you get a peptide synthesis that way. What aminoglycosides do is I'm just going to change to black. What happens is, so this is chugging along here. When the aminoglycosides get into a cell, they come and they actually bind to the reading frame. So if this is the aminoglycoside. So they bind here. And what they do is it distorts the reading frame. Essentially what it does is you start missing bases and things like that in the transcription cycle because they've got this aminoglycoside bound to them. And then it's having the same effect as inducing a nonsense mutation. So nonsense mutation meaning that you don't get a functional protein being made. You've got an early stop codon and things like that. So basically, although not acting on DNA, it has the same effect as a mutation by preventing the translation of DNA into protein, or more specifically mRNA into protein. So what then happens, so these are, as opposed to other antibacterials which act on the ribosome as well and on protein synthesis, these drugs in particular are bactericidal. So these are, again, the bactericidal class, because what happens is you end up getting an accumulation of abnormal proteins. So these proteins that have been trying to be made end up misfolding. You get weird lengths. They don't have the properties that the normal proteins should have. So as they can accumulate, they put the cell under stress, and when a significant amount of stress is reached, the cell dies. Again, similar to penicillins and beta-lactams and all those kinds of things, these have a two-step model of death, of killing the cell. Firstly, that accumulation of normal protein and that stress response actually results in the bacteria becoming leaky. And as it becomes leaky, you can get more inside. So if you got this bacteria here, you got the little drug out here, you might have lots of the drug, but due to a variety of mechanisms that I'll talk about in a sec, you might only get maybe like 2 or 3% of those getting into the cell, and the rest kind of bounce off, right? So these guys get into the cell and they bind to those ribosomes. They come in, they bind, they inhibit the protein synthesis. The accumulation of proteins then allows for these little, basically little pores, but the membrane becomes leaky. It becomes less good at pumping things it doesn't want out of the cell, out of the cell. So all these things that were getting kind of reflected off the membrane can now enter. And what happens then is you can get very high doses of the aminoglycoside in the bacterial cell, and what that does is you then get full ribosomal blockade, so you completely stop translation, and as soon as you get ribosomal blockade, the cell can't survive. But yeah, the cell dies very soon after that because it has no proteins. It has, instead of having just a few dysfunctional proteins, it now has no protein synthesis at all. So 2 stages. So one is getting in and causing stress. And then stage 2, you get ribosomal blockade. Which just causes death. Cool. There are quite a few methods of developing resistance to aminoglycosides. And just using here amikacin as an example, all of these functional groups, they're kind of out on these rings. And if I go back up to here, you can see there's a lot of functional groups. All those groups are susceptible to modification. So what bacteria can do is they can actually start encoding enzymes which can bind to these exposed regions, and there's lots of them, and modify those. And by enzymatically modifying them, you can reduce entry. So again, it can't penetrate in through the membrane. It can also, that's the main reason. It can also affect its binding to the ribosomes. It can basically affect its entire function. And so by bacteria encoding enzymes to modify these regions, you get very high level resistance. Something else I'd just like to point out is just when this was published, this was from 1999. So I know that antimicrobial resistance has been kind of a big thing in the media in the past few years, but it's important to realize that we've known about antibiotic resistance for a very, very, very long time. Only a few years after we first discovered penicillin, we discovered that bacteria were resistant to penicillin. So it's been a problem for a very, very long time, and hence this resistance hasn't sprung out of nowhere. It's been building up over decades. So in terms of these modifications here on these kind of residues, it's often gram-negative bacteria which can encode those enzymes. So gram-negative can do enzymatic modification. We then, there are a few other ways. So the bacteria itself can start encoding ways to either change its membrane, so modifying its outer membrane. If it's a gram-negative, they often do this so they can modify outer membrane. And by modifying that outer membrane, again, you're stopping it coming in the first place. You can also start encoding different pumps and proteins which can actually pump it back out. So you might have this bacteria, and so now not only is it harder for the drug to get in the first place, but when something does eventually manage to get through that membrane, it ends up getting pumped straight back out again via a protein pump, protein channel. So this is called increased efflux, when you're able to pump out more of the drug. And obviously if you're pumping out the drug, it's not able to bind to the ribosome. And then one of the final ways that you can get resistance is through modifying the ribosome itself. So if you get ribosomal mutations, you can also prevent the the aminoglycoside from binding to the ribosome, but can't bind the ribosome, it can't inhibit protein synthesis, and so it has no effect. So again, that can do very high level resistance. So this is generally fairly low level resistance. Whereas enzymatic modification here, that is high level resistance, and also ribosomal mutations. That's also high level resistance. So just to list them all out again, so you can have increased efflux / decreased entry as one. You can then also have enzymatic modification. And lastly, you can have ribosomal mutations. These two give high resistance, and this one has got moderate resistance. Cool. One more thing before we finish up this video, I just want to mention aminoglycosides. They're actually quite a toxic drug. So although with all of our antibacterials, they're all trying to target things, target bacterial cells more so than our cells. So the aminoglycosides, while they do bind quite specifically to the bacterial ribosome, they do also have some cross-reactivity with our ribosomes and with our cells, so you can get some significant toxicity with that. In particular, they can be very toxic to the kidneys, and they can be ototoxic, which means they affect your hearing. So we have to be careful when, if a child comes in with an infection, with like a chest infection or sepsis, something like that, we have to be careful in giving aminoglycosides, because we could cause that child to become deaf for life. And likewise, in a patient with renal failure, you want to be careful giving aminoglycosides, as they're toxic to the kidneys as well, and could further escalate that kidney failure, which is not good. That's all for today. As always, if you have any questions or any videos you'd like me to do, or anything you'd like me to explain further, please leave a comment below. If not, thank you guys for watching.